Describe the pathophysiological mechanisms that can lead to acute kidney injury. Discuss the differences between prerenal, intrinsic, and postrenal causes of AKI and provide examples of each. Answer. Acute kidney injury is characterized by a sudden decline in kidney function, typically defined as an increase in serum creatinine of 0.3 mg/dL or a reduction in urine output. The pathophysiology of AKI can be categorized into three main types. Prerenal causes. These occur due to a decrease in renal perfusion, often due to dehydration, heart failure, or shock. In prerenal azotemia, the kidney parenchyma is typically intact, but renal blood flow is compromised. A classic example is acute tubular necrosis and secondary to hypovolemia. Mechanism. Decreased blood flow leads to a reduction in glomerular filtration rate (GFR) due to the activation of the renin-angiotensin-aldosterone system (ROS), promoting vasoconstriction of afferent arterioles. Intrinsic causes. These result from direct damage to the renal parenchyma, such as acute tubular necrosis, acute interstitial nephritis, or glomerulonephritis. Intrinsic AKI often presents with casts or protein in the urine. Mechanism. Cellular injury from nephrotoxins e.g. aminoglycosides. Inflammation or ischemia leads to tubular cell death and subsequent slowing of cells, causing obstruction and reduced GFR. Postrenal causes. These involve obstruction of urine flow anywhere from the collecting ducts to the urethra. Conditions such as kidney stones, prostate enlargement, or tumors can lead to postrenal AKI. Mechanism. Obstruction leads to increased intratubular pressure, resulting in backflow into the renal parenchyma and reduced filtration. Early recognition and removal of the obstruction are critical to preventing permanent damage. Guidelines. Diagnosis often involves a comprehensive clinical history, urine analysis, and imaging studies. The National Kidney Foundation recommends utilizing urine output monitoring and serum creatinine trends for timely intervention. Explain the role of serum creatinine and blood urea nitrogen (BUN) in assessing renal function. How should these tests be interpreted in conjunction with urine output data to determine the cause of acute kidney injury? Answer. Serum creatinine and blood urea nitrogen (BUN) are crucial markers for assessing renal function. Serum creatinine. This is a byproduct of muscle metabolism and is filtered by the kidneys. Elevated levels indicate impaired kidney function but can be influenced by muscle mass and diet. Normal ranges are approximately 0.6–1.2 dL. Blood urea nitrogen (BUN). BUN measures the amount of nitrogen in the blood from urea, which results from protein metabolism. Normal levels range from 7 to 0 EDL. BUN can also reflect hydration status. For instance, in dehydration, BUN may rise disproportionately compared to creatinine. Interpretation. In AKI, the ratio of BUN to creatinine can provide insights into the underlying cause. A BUN creatinine ratio 20:1 typically suggests a prerenal cause, often due to volume depletion e.g. dehydration. A BUN creatinine ratio 10:1 suggests intrinsic renal disease as urea reabsorption is impaired. It is essential to consider urine output data. Oliguria urine output 0.5 kg alongside elevated BUN and creatinine strongly indicates AKI. Discuss the implications of PSA testing in prostate cancer screening, including the controversies surrounding its use. What guidelines should practitioners follow when advising patients about PSA screening? Answer. Prostate-specific antigen (SSA) testing is a blood test used for screening and monitoring prostate cancer. Its use is controversial due to concerns about overdiagnosis and overtreatment. Benefits. PSA testing can help detect prostate cancer at an early stage, potentially reducing mortality rates. Early intervention can lead to better treatment outcomes. Risks. PSA is not cancer-specific. Elevated levels can occur in benign conditions such as benign prostatic hyperplasia (BH) or prostatitis, leading to unnecessary biopsies and anxiety. The U.S. Preventive Services Task Force has highlighted that the potential harms of screening may outweigh the benefits in certain populations. Guidelines. Shared decision-making. It is crucial to engage patients in discussions about the risks and benefits of PSA screening, especially for men aged 55 to 69 years, who should be given the option to be screened after considering their individual risk factors, including family history and race. Follow-up. If the PSA level is elevated, for AGML, further evaluation through repeat testing and possibly biopsy should be considered. The American Neurological Association (AWA) recommends a discussion of the patient's values and preferences during this process. What are the common types of nephrolithiasis and what are the recommended management strategies for each type? Include relevant dietary and pharmacological interventions. Answer: nephrolithiasis or kidney stones can be classified into several types, each requiring specific management strategies. Calcium stones, calcium oxalate, and calcium phosphate management. Increased fluid intake, 2-3 day to dilute urine is crucial. Dietary modifications include reducing oxalate-rich foods, e.g. spinach, nuts for calcium oxalate stones, and maintaining adequate dietary calcium intake 1000-1200 mg day to reduce oxalate absorption. Pharmacological interventions. Thiazide diuretics may be prescribed to decrease urinary calcium excretion. Uric acid stones management. Increased hydration and alkalinization of urine. Target urine pH 6 can help dissolve these stones. Dietary changes should include reducing purine-rich foods, e.g. red meat, shellfish. Pharmacological interventions. Allopurinol may be utilized to lower uric acid levels in patients with recurrent stones. Struvite stones management. These stones are often associated with urinary tract infections. Treatment may involve antibiotic therapy and surgical intervention, e.g. percutaneous nephrolithotomy for large stones. Guidelines. Preventive measures focus on treating urinary infections and increasing hydration. Cystine stones management. Increased fluid intake is critical to dilute urine and prevent stone formation. A low-sodium diet and medication to reduce cystine levels may also be beneficial. Pharmacological interventions. Tiaprenin or penicillamine may be prescribed to help reduce urinary cystine concentrations. Mr. Thompson, a 65-year-old man, presents to the clinic with complaints of erectile dysfunction, ed. He has a history of hypertension and is currently taking lisinopril. After discussing his symptoms, you consider treatment options. What considerations should you take into account when recommending a phosphodiesterase type 5 PDE inhibitor for Mr. Thompson, and what other management strategies could you suggest? Answer: when considering treatment for Mr. Thompson's erectile dysfunction with a phosphodiesterase type 5 PDE inhibitor, e.g. sildenafil, tadalafil, several factors must be evaluated. Cardiovascular health. Given Mr. Thompson's history of hypertension, it is essential to assess his overall cardiovascular risk. ED inhibitors can lead to vasodilation and may have interactions with nitrates, e.g. nitroglycerin, which can cause significant hypotension. A thorough evaluation of his cardiovascular status is crucial before prescribing concurrent medications. Review all medications, especially those for hypertension. Adjustments or monitoring may be necessary to avoid potential interactions. Lisinopril itself does not contraindicate PDE inhibitors, but requires caution with blood pressure management. Underlying causes. ED can be multifactorial, involving psychological, hormonal, or vascular components. Addressing lifestyle factors such as smoking cessation, weight loss, and increased physical activity is essential. Discussing the psychological aspects and considering counseling or therapy may also be beneficial. Patient preferences and expectations. Engage Mr. Thompson in shared decision-making, discussing the potential benefits and side effects of ED inhibitors. Ensure he understands that while these medications can improve erectile function, they do not increase sexual desire or resolve underlying issues. Alternative treatments. ED inhibitors are contraindicated or ineffective. Other options include vacuum erection devices, penile injections, or intraurethral medications. Referral to a urologist may be appropriate for further evaluation or specialized treatments. Guidelines. The American Urological Association recommends a comprehensive approach to managing ED, including lifestyle modifications and a thorough assessment of underlying conditions. Differentiate between the various types of urinary incontinence, including stress urge overflow and functional incontinence. What are the primary management strategies for each type? Answer: urinary incontinence (UI) can be categorized into several types, each requiring distinct management strategies. Stress incontinence. This occurs when pressure on the bladder, e.g. during coughing, sneezing, or exercise, exceeds the resistance of the sphincter mechanism. Management. Pelvic floor exercises, Kegel exercises are first-line therapies. Behavioral interventions such as bladder training and weight loss are also beneficial. Surgical options include midurethral sling procedures or Birch-Kulper suspension. Urge incontinence, characterized by a sudden and intense urge to urinate, often leading to involuntary loss of urine. Management. Behavioral modifications, e.g. bladder training, scheduled voiding, and anticholinergic medications, e.g. oxybutynin, tolterodine are commonly used. Neuromodulation, e.g. sacral nerve stimulation, may be considered for refractory cases. Overflow incontinence. This type occurs when the bladder is unable to empty completely, leading to overdistension and involuntary leakage. Management: identifying and treating the underlying cause, e.g., bladder outlet obstruction for EH, is critical. Intermittent catheterization may be required in severe cases. Medications that reduce bladder outlet resistance, e.g., alpha blockers, can also help. Functional incontinence: this arises from physical or cognitive impairments that prevent timely access to the toilet, e.g., mobility issues. Management strategies focus on improving accessibility, e.g., removing obstacles, prompting voiding, and using absorbent products. Rehabilitation programs to enhance mobility may be appropriate. Guidelines: the Society of Urodynamics, Female Pelvic Medicine, and Urogenital Reconstruction (SUFU) emphasizes individualized treatment plans based on the type of incontinence and the patient's overall health status. Compare and contrast the mechanisms of action, indications, and potential side effects of loop diuretics versus thiazide diuretics. In what clinical scenarios might each type of diuretic be preferred? Answer: diuretics are commonly used to manage conditions such as hypertension and edema. Loop diuretics and thiazide diuretics have distinct mechanisms of action, indications, and side effects. Loop diuretics, e.g., furosemide, bumetanide. Mechanism of action: they inhibit the NAC-hypocal transporter in the thick ascending limb of the loop of Henle, leading to increased excretion of sodium chloride and water. Indications: loop diuretics are preferred in conditions requiring rapid diuresis such as acute heart failure, pulmonary edema, and renal failure. Side effects: electrolyte imbalances, e.g., hypokalemia, hyponatremia, toxicity, dehydration, and metabolic alkalosis. Thiazide diuretics, e.g., hydrochlorothiazide, chlorphalidone. Mechanism of action: they inhibit the NACL cotransporter in the distal convoluted tubule, leading to increased sodium and water excretion. Indications: thiazides are commonly used for hypertension management and in mild edema. They are often the first-line treatment for essential hypertension. Side effects: electrolyte imbalances, e.g., hypokalemia, hypocalcemia, metabolic syndrome, elevated glucose and lipids, and potential exacerbation of gout due to increased uric acid levels. Clinical scenarios: loop diuretics are indicated in patients with severe fluid overload or renal impairment where rapid diuresis is needed. Thiazide diuretics are preferred for long-term management of hypertension and mild fluid retention. Guidelines: the American Heart Association (AHO) recommends the use of thiazide diuretics as first-line agents in managing hypertension unless contraindicated. Monitoring electrolyte levels is essential when prescribing either class of diuretics. Discuss the pathophysiology, clinical features, and management of glomerulonephritis. How does the treatment differ between nephritic and nephrotic syndromes? Answer: glomerulonephritis, GN, is an inflammatory condition affecting the glomeruli, leading to renal impairment. It can be categorized into two main types: nephritic and nephrotic syndromes. Pathophysiology: nephritic syndrome, characterized by inflammation of the glomeruli, often due to post-infectious causes, e.g., post-streptococcal GN, leading to hematuria, hypertension, and oliguria. Immune complex deposition and complement activation are key mechanisms. Nephrotic syndrome results from damage to the glomerular filtration barrier, leading to significant proteinuria, 3.5 gram state, hypoalbuminemia, and edema. Conditions such as minimal change disease and focal segmental glomerulosclerosis are common causes. Clinical features: nephritic syndrome. Symptoms include hematuria, proteinuria, mild edema, hypertension, and reduced urine output. Patients may also present with renal impairment. Nephrotic syndrome. Patients exhibit heavy proteinuria, hypoalbuminemia, generalized edema, and hypolipidemia. Management: nephritic syndrome. Treatment focuses on managing hypertension and fluid overload. Corticosteroids or immunosuppressive therapy may be necessary for specific causes, e.g., IgA nephrotic syndrome. The mainstay of treatment includes corticosteroids for primary causes and managing complications like edema and hypolipidemia. Diuretics may be used for symptomatic relief. In cases of secondary nephrotic syndrome, e.g., diabetes, managing the underlying condition is crucial. Guidelines: the Kidney Disease Improving Global Outcomes (KDIGO) recommends individualizing treatment based on the underlying etiology and severity of the syndrome, with regular monitoring of renal function and proteinuria. What are the indications for transurethral resection of the prostate (TURP), and what potential complications should be discussed with patients prior to the procedure? Answer: transurethral resection of the prostate (TURP) is a surgical procedure commonly performed for symptomatic benign prostatic hyperplasia (BPH) indications. Moderate to severe low urinary tract symptoms (LUTs) that are refractory to medical management. Complications of BPH, such as recurrent urinary tract infections, bladder stones, or acute urinary retention. Significant impact on the patient's quality of life due to urinary symptoms. Potential complications. Immediate complications. Bleeding is the most common complication, with a risk of requiring blood transfusion in about 1–2% of cases. The risk of perforation of the prostate or bladder may occur during the procedure. Long-term complications, urinary incontinence. Varying degrees of incontinence can occur, with rates around 5–0%. Erectile dysfunction. The incidence of erectile dysfunction post-TURP varies but can be as high as 1–2%. Discussing the potential for changes in sexual function is essential. Retrograde ejaculation. This is a common outcome where semen enters the bladder instead of exiting through the urethra, affecting fertility. Transurethral resection syndrome, TER syndrome. This rare but serious complication can occur due to the absorption of irrigation fluid, leading to hyponatremia and fluid overload. Guidelines. The American Urological Association recommends discussing the potential benefits and risks of TURP with patients, thoroughly ensuring informed consent. Preoperative assessment of the patient's overall health and the severity of BPH symptoms is critical. Describe the role of immunosuppressive therapy in the management of glomerulonephritis. What are the indications for its use and what potential side effects should be monitored in patients receiving these therapies? Answer. Immunosuppressive therapy plays a vital role in managing certain types of glomerulonephritis, particularly those with an autoimmune or inflammatory component. Indications for use. Primary glomerular diseases. Conditions such as minimal change disease, focal segmental glomerulosclerosis, and diffuse proliferative glomerulonephritis often require immunosuppressive agents to control inflammation and proteinuria. Secondary glomerular diseases. Diseases like lupus nephritis necessitate immunosuppressive therapy to manage the underlying autoimmune process. Commonly used agents. Corticosteroids. Prednisone is frequently used for its rapid anti-inflammatory effects. Calcineurin inhibitors. Drugs like cyclosporine and tacrolimus are used in steroid-resistant cases or as steroid-sparing agents. Other agents, mycophenolate mofetil and azathioprine, are used for maintenance therapy, particularly in lupus nephritis. Potential side effects. Infections. Immunosuppressive therapy increases the risk of opportunistic infections due to a compromised immune response. Regular monitoring for signs of infection is crucial. Metabolic complications. Patients may experience weight gain, hypoglycemia, and hypertension, especially with long-term corticosteroid use. Renal toxicity. Monitoring renal function is essential, particularly with calcineurin inhibitors, as they can lead to nephrotoxicity. Guidelines. The Kidney Disease Improving Global Outcomes (KDIGO) provides recommendations on the use of immunosuppressive therapy, emphasizing the need for individualized treatment plans based on the type of glomerulonephritis, disease severity, and patient characteristics. Regular follow-up is essential to assess response to therapy and monitor for side effects. Discuss the role of osteoblasts and osteoclasts in bone remodeling. How does this process relate to conditions such as osteoporosis? Answer. Osteoblasts are responsible for bone formation, synthesizing and secreting the bone matrix, while osteoclasts are involved in bone resorption, breaking down bone tissue. This dynamic process of bone remodeling is essential for maintaining bone health and adapting to mechanical stress. In osteoporosis, there is an imbalance in this remodeling process, with increased osteoclast activity leading to greater bone resorption and formation. This results in reduced bone density and increased fracture risk. Key guidelines for managing osteoporosis emphasize the importance of adequate calcium and vitamin D intake, regular weight-bearing exercise, and pharmacological interventions like bisphosphonates to inhibit osteoclast activity. The National Osteoporosis Foundation recommends a DEXA scan for assessing bone density in at-risk populations, particularly postmenopausal women and the elderly. A 35-year-old female presents with lateral knee pain after a skiing accident. What clinical examination findings would support a diagnosis of an anterior cruciate ligament ACL tear? Answer. To diagnose an ACL tear, a thorough physical examination is essential. Key findings may include positive Lachman test, increased anterior translation of the tibia relative to the femur when the knee is at 2–3 degrees of flexion indicates ACL injury, positive anterior draw test with the patient supine and the knee flexed to 90 degrees, excessive forward movement of the tibia suggests an ACL tear, swelling and hemarthrosis. Rapid swelling post-injury is typical due to bleeding into the joint space, limited range of motion. Patients often demonstrate difficulty in fully extending the knee due to pain or swelling. Guidelines from the American Academy of Orthopedic Surgeons recommend MRI as a follow-up diagnostic study to confirm ACL injury and assess any associated meniscal tears. Mr. Thompson, a 62-year-old male, presents with chronic knee pain, morning stiffness lasting less than 30 minutes, and joint swelling. After an evaluation, he is diagnosed with osteoarthritis. What treatment options should be recommended considering his condition and any potential comorbidities? Answer: in managing osteoarthritis, a multimodal approach is recommended. Non-pharmacological interventions, physical therapy, a structured exercise program to improve strength and flexibility, weight management. Reducing body weight can significantly alleviate knee load and pain. Assistive devices, use of knee braces or canes for support. Pharmacological options, acetaminophen. First-line treatment for mild to moderate pain, NSAIDs, ibuprofen, effective for reducing inflammation and pain, but must be used cautiously in patients with cardiovascular or gastrointestinal comorbidities. Intra-articular corticosteroid injections provide temporary relief from inflammation. Surgical options. If conservative measures fail, options include arthroscopy, osteotomy, or total knee arthroplasty, especially if there is significant joint damage or loss of function. Guidelines from the American College of Rheumatology advocate a tailored treatment plan based on the patient's individual needs and comorbid conditions. Explain the pathophysiological mechanisms underlying gout. How do uric acid-lowering agents like allopurinol function in the management of this condition? Answer: gout is characterized by the deposition of monosodium urate crystals in joints due to hyperuricemia, typically defined as serum uric acid levels exceeding 6.8 mg/dL. The underlying mechanism involves either overproduction or underexcretion of uric acid. Allopurinol, a xanthine oxidase inhibitor, decreases uric acid production by inhibiting the enzyme responsible for converting hypoxanthine to xanthine and subsequently to uric acid. The goal of allopurinol therapy is to lower uric acid levels to prevent acute attacks and the progression of gouty arthritis. The American College of Rheumatology guidelines recommend starting allopurinol for patients with frequent gout attacks or chronic tophaceous gout. Regular monitoring of serum uric acid levels is essential to ensure therapeutic effectiveness and avoid potential side effects such as skin rash or liver toxicity. What are the advantages of using MRI over X-ray for evaluating soft tissue injuries in the musculoskeletal system? Answer: MRI offers several advantages over X-ray in assessing soft tissue injuries, including detailed soft tissue visualization. MRI provides superior imaging of ligaments, tendons, cartilage, and muscles, allowing for the identification of tears, sprains, and degenerative changes. No ionizing radiation. MRI utilizes magnetic fields and radio waves, making it safer for repeated imaging, particularly in younger patients or those requiring follow-up. Assessment of bone marrow edema. MRI can detect subtle bone injuries and stress fractures that may not be visible on X-rays. Multiplanar imaging. MRI allows imaging in multiple planes, providing comprehensive anatomical information. The American College of Radiology recommends MRI as the preferred imaging modality for diagnosing acute knee injuries and conditions like meniscal tears or ligamentous injuries due to its high sensitivity and specificity. Discuss the mechanism of action of muscle relaxants in treating acute muscle spasms and outline the potential risks associated with their use. Answer: muscle relaxants such as cyclobenzaprine act primarily in the central nervous system to reduce muscle spasms. They inhibit the transmission of nerve impulses in the spinal cord and brain, leading to decreased muscle tone and spasms. Potential risks associated with muscle relaxant use include sedation and drowsiness. Many muscle relaxants can cause significant sedation, increasing the risk of falls and accidents. Dependence and withdrawal. Prolonged use can lead to tolerance and dependence, with withdrawal symptoms upon discontinuation. Anticholinergic effects. Some muscle relaxants can cause dry mouth, blurred vision, and urinary retention, particularly in older adults. The American Academy of Family Physicians advises limiting the use of muscle relaxants to short-term treatment in conjunction with physical therapy and other non-pharmacological measures to minimize risks. A 45-year-old male presents with a midshaft humeral fracture after fall. What are the critical considerations in the management of this fracture? Answer: the management of a midshaft humeral fracture involves several key considerations. Initial assessment. A thorough physical examination to assess for neurovascular compromise, as radial nerve injury can occur with humeral shaft fractures, leading to wrist drop. Imaging. Obtain X-rays to confirm the fracture type, e.g. transverse, spiral, or comminuted, and check for any associated injuries. Non-operative management. Most midshaft humeral fractures can be treated conservatively with a functional brace or sling, allowing for early mobilization. Surgical intervention indicated in cases of non-union, significant displacement, or when there is associated nerve injury requiring repair. Rehabilitation. Early physical therapy is crucial to restore range of motion and strength post-fracture. Guidelines from the American Academy of Orthopedic Surgeons recommend close follow-up to monitor healing and address any complications that may arise. What laboratory tests are essential in evaluating a patient suspected of having rheumatoid arthritis, and what do the results indicate? Answer: key laboratory tests for diagnosing rheumatoid arthritis include rheumatoid factor (RF). A positive result supports the diagnosis but is not definitive, as it can also be positive in other conditions. Anti-citrullinated protein antibody and CP. More specific for RA, a positive test significantly increases the likelihood of diagnosis. Erythrocyte sedimentation rate, ESA, and C-reactive protein (CRP). If these tests assess inflammation levels at elevated, results indicate active inflammation commonly associated with RA. Complete blood count (CBC) to check for anemia, which could accompany chronic inflammatory conditions. The American College of Rheumatology guidelines recommend using a combination of these tests alongside clinical findings to confirm a diagnosis of RA, as no single test is definitive. A 50-year-old female reports chronic low back pain radiating down her left leg. What clinical features would indicate a herniated lumbar disc, and what diagnostic approach should be taken? Answer: clinical features indicative of a herniated lumbar disc include radicular pain, pain that radiates down the leg, often following the distribution of a specific nerve root, e.g. L or S. Positive straight leg raise test. Pain elicited when the straight leg is raised, indicating nerve root irritation. Neurological signs. Weakness or sensory loss in the affected dermatomes, e.g. weakness in dorsiflexion indicates ill involvement. The diagnostic approach should begin with a detailed history and physical examination, followed by imaging studies. MRI is the gold standard for confirming a herniated disc, as it provides excellent visualization of soft tissues, including intervertebral discs and nerve roots. The American Academy of Orthopedic Surgeons suggests conservative management as the first-line treatment unless there are severe neurological deficits or failure to improve with conservative care. What lifestyle modifications should be recommended for a postmenopausal woman diagnosed with osteoporosis to help manage her condition? Answer: for a postmenopausal woman diagnosed with osteoporosis, the following lifestyle modifications are essential. Nutritional interventions. Calcium intake. Aim for 1200 mg of calcium daily through dietary sources, e.g. dairy products, leafy greens, or supplements. Vitamin D. Adequate vitamin D intake, 800-1000 IU daily, is crucial for calcium absorption. Consider supplementation based on serum levels. Physical activity. Weight-bearing exercises. Engage in activities such as walking, dancing, or resistance training to strengthen bones. Balance and flexibility exercises. Practices like Tai Chi can help reduce fall risk. Avoiding tobacco and excess alcohol. Smoking cessation and limiting alcohol intake to 1 drink per day can help improve bone health. What physiological changes occur in a patient with chronic obstructive pulmonary disease (COPD) that lead to respiratory acidosis, and how does the body attempt to compensate? Answer: in patients with COPD, the obstruction of airflow due to chronic inflammation and structural changes in the lungs leads to hypoventilation, resulting in an accumulation of carbon dioxide (CO) in the bloodstream. This increased CO level causes a shift in the acid-base balance, leading to respiratory acidosis. The acid-base equation shows that CO reacts with water to form carbonic acid, HCl, which dissociates into hydrogen ions, H, and bicarbonate, HCl. The resulting increase in hydrogen ion concentration lowers the blood pH, causing acidosis. To compensate for this metabolic disturbance, the body employs renal mechanisms. The kidneys respond by increasing the reabsorption of bicarbonate, thus providing a buffer to the excess hydrogen ions, which helps raise the blood pH toward normal. This renal compensation takes time, typically several hours to days, making it important for clinicians to monitor the patient's acid-base status closely. Moreover, understanding the interplay between respiratory mechanics and acid-base balance is crucial in managing COPD effectively, especially during exacerbations when respiratory acidosis may worsen, necessitating interventions like bronchodilators, corticosteroids, and sometimes non-invasive ventilation. Which radiographic findings are typically seen on a chest X-ray in a patient with a large pleural effusion, and what is the recommended diagnostic approach? Answer: a large pleural effusion is characterized radiographically by a homogeneous opacity that typically appears in the lower lung fields with blunting of the costophrenic angles. This blunting occurs because the fluid accumulates in the pleural space, creating a silhouette sign that obscures the border between the lung and diaphragm. In more significant cases, the mediastinum may shift away from the affected side due to the mass effect of the fluid. To confirm the diagnosis and assess the nature of the pleural effusion, thoracentesis is recommended. This procedure involves inserting a needle into the pleural space to withdraw fluid for analysis. Light's criteria can be applied to categorize the effusion as transsudative or exudative based on the levels of protein and lactate dehydrogenase (LDH) in the pleural fluid compared to serum levels. Identifying the type of effusion is crucial as it guides further diagnostic and therapeutic decisions. For example, transsudative effusions are often associated with systemic conditions such as congestive heart failure, while exudative effusions can indicate infection, malignancy, or inflammatory processes. Further imaging, such as ultrasound or CT, may be utilized to guide thoracentesis and assess the effusion's extent. Mr. Jackson, a 62-year-old man with a history of deep vein thrombus (DVT), presents to the emergency department with sudden onset shortness of breath, chest pain, and hemoptysis. His vitals show a heart rate of 110 bpm, blood pressure of 90/60 mmHg, and oxygen saturation of 88%. What is the most likely diagnosis, and what should be the immediate course of action? Answer: in Mr. Jackson's case, his presentation of sudden onset shortness of breath, pleuritic chest pain, and hemoptysis combined with his history of deep vein thrombus (DVT raises a strong suspicion for pulmonary embolism (P). The underlying mechanism involves a clot that has dislodged from a deep vein and traveled to the pulmonary vasculature, obstructing blood flow and resulting in acute respiratory and hemodynamic compromise. Initial management should focus on stabilizing the patient. Administering supplemental oxygen is critical to improve hypoxemia, aiming for saturation levels above 90%. IV fluids may be necessary to support blood pressure, especially given his hypotension. 9 to 6 Hg. Anticoagulation therapy is the cornerstone of treatment, with unfractionated heparin or low molecular weight heparin, e.g. enoxaparin, being standard approaches. If the patient shows signs of hemodynamic instability or a massive PE, thrombolytic therapy may be indicated to rapidly dissolve the clot. While awaiting imaging, a CT pulmonary angiogram (PA) should be performed to confirm the diagnosis, which is the gold standard. If the patient is too unstable for a CT-PA, a bedside echocardiogram may provide evidence of right ventricular strain, further supporting the diagnosis of PE. Explain the pathophysiological differences between obstructive and restrictive lung diseases as seen on pulmonary function tests (PFTS), focusing on spirometry results. Answer: understanding the differences between obstructive and restrictive lung diseases is fundamental in interpreting pulmonary function tests (PFTS). In obstructive lung diseases such as asthma and chronic obstructive pulmonary disease (COPD), the primary problem is increased airway resistance leading to difficulty exhaling air from the lungs. On spirometry, patients typically show a decreased forced expiratory volume in 1 second (FEV) and a reduced FEF ratio of 70%. This reduction is indicative of the obstructive nature of the disease, as the forced vital capacity (FEC) may remain normal or only slightly diminished. Conversely, restrictive lung diseases such as pulmonary fibrosis or pleural diseases are characterized by a decrease in lung compliance, making it difficult to fully expand the lungs. In these conditions, both FEV and FVC are reduced. However, the FEF ratio is usually normal or elevated because both values decrease proportionally. Additionally, lung volumes, including total lung capacity (TLC) and residual volume (RV), are reduced, reflecting the overall restriction in lung expansion. Recognizing these patterns is crucial for diagnosing the specific type of lung disease and guiding appropriate management strategies. What are the indications for mechanical ventilation in a patient with acute respiratory distress syndrome (ARDS), and what are key settings that should be adjusted to prevent ventilator-induced lung injury? Answer: in the management of acute respiratory distress syndrome (ARDS), mechanical ventilation plays a crucial role, particularly when patients exhibit severe hypoxemia and respiratory failure. The main objective is to provide adequate oxygenation while minimizing ventilator-induced lung injury (VILI). Key ventilator settings must be adjusted to achieve this balance. Firstly, low tidal volume ventilation, typically 4 Ag of ideal body weight, is employed to prevent overdistension of alveoli and reduce the risk of volatrauma. Utilizing this approach has been shown to improve outcomes in ARDS patients. The application of positive end-expiratory pressure PEEP is also vital. It helps to keep the alveoli open, improving oxygenation and preventing atelectasis, but must be carefully monitored to avoid barotrauma. Additionally, monitoring plateau pressures is essential as they should remain below 30 centimeters high to minimize the risk of lung injury. In some cases, permissive hypocapnia may be allowed, meaning that a higher carbon dioxide level is tolerated to reduce airway pressures. The combination of these strategies aims to optimize ventilation, improve gas exchange, and reduce mortality associated with ARDS. A 45-year-old patient with a smoking history presents with a chronic cough and weight loss. A chest CT scan reveals a centrally located mass with lymphadenopathy. What is the most likely diagnosis, and which diagnostic procedure should be performed next? Answer: in this clinical scenario, MS. Rodriguez's presentation, including her smoking history, chronic cough, and weight loss, is highly suggestive of lung cancer. Given the chest CT findings of a centrally located mass with lymphadenopathy, small cell lung cancer (SLC) is a strong consideration, particularly due to its association with smoking and its aggressive nature. To confirm the diagnosis, a bronchoscopy with biopsy is the preferred next step. This procedure allows direct visualization of the tracheobronchial tree and provides a method to obtain tissue samples for histopathological examination, crucial for establishing the type of lung cancer. Early diagnosis is vital as it can impact the treatment options available, including chemotherapy, radiation, or surgical interventions. In cases where bronchoscopy is inconclusive, further imaging studies or techniques such as mediastinoscopy may be employed to assess lymph node involvement and obtain more definitive tissue samples. Early and accurate diagnosis of lung cancer is essential in managing the disease effectively and improving the patient's prognosis. What is the role of bronchodilators in the management of asthma, and how do beta-agonists and anticholinergics differ in their mechanisms of action? Answer: in asthma management, bronchodilators are essential for alleviating acute bronchoconstriction and improving airflow. There are two primary classes of bronchodilators: beta-agonists and anticholinergics, each working through distinct mechanisms. Beta-agonists, such as albuterol, short-acting, and salmeterol, long-acting, target beta-2 adrenergic receptors in the bronchial smooth muscle. Activation of these receptors leads to muscle relaxation and subsequent bronchodilation, which is critical during asthma attacks when bronchospasm occurs. Anticholinergics, such as ipratropium bromide, inhibit the action of acetylcholine on muscarinic receptors, preventing bronchoconstriction. These medications are often utilized as adjunct therapy in asthma management and are particularly effective in chronic obstructive pulmonary disease (COPD) patients. The combination of these medications can be beneficial, especially in patients who experience inadequate control with beta-agonists alone. Understanding the role of bronchodilators and their mechanisms allows healthcare providers to tailor treatment strategies effectively to improve asthma control and enhance patient outcomes. MS. Rodriguez, a 50-year-old woman with a history of diabetes, presents with fever, productive cough, and pleuritic chest pain. Chest X-ray shows a right lower lobe consolidation. Sputum culture reveals gram-positive diplococci. What is the most likely pathogen, and what is the first-line treatment? Answer: MS. Rodriguez's clinical presentation, which includes fever, productive cough, and pleuritic chest pain, combined with the chest X-ray showing consolidation, indicates community-acquired pneumonia (CAP). The sputum culture revealing gram-positive diplococci strongly suggests Streptococcus pneumoniae, the most common pathogen responsible for CAP. In managing this condition, the first-line treatment for uncomplicated CAP caused by pneumonia is typically amoxicillin, especially if the patient does not have significant comorbidities or prior antibiotic exposure. In cases of severe pneumonia or where resistant strains are suspected, a broader spectrum antibiotic such as levofloxacin or ceftriaxone may be indicated. The decision to hospitalize a patient with pneumonia is influenced by various factors, including the severity of symptoms, vital signs, and the presence of underlying comorbidities. For example, the CUB-65 score can assist in assessing the need for hospitalization. Patients with a score of 2 or higher typically warrant inpatient management due to the increased risk of complications. Supportive care, such as oxygen supplementation and hydration, is also crucial. It's essential to monitor the patient's clinical status and modify treatment based on their response, including the consideration of further imaging or follow-up evaluations if the patient fails to improve. Describe the pathophysiology and clinical presentation of tension pneumothorax and outline the immediate management steps. Answer. In the assessment of asthma, pulmonary function tests (PFTS) play a critical role in diagnosing and monitoring the condition. Spirometry is the primary tool used to evaluate airflow obstruction and reversibility, which is a hallmark of asthma. During a spirometry test, patients typically demonstrate reduced forced expiratory volume in 1 second, FEV, and a decreased FEV ratio 70%, indicating obstructive lung disease. However, what distinguishes asthma from other obstructive diseases is the reversibility of airflow obstruction. After administration of a bronchodilator, patients with asthma usually show an increase in FEV by more than 12% and 200 ml, confirming the diagnosis. In addition to spirometry, peak expiratory flow (PEF) monitoring can be used in asthma management. Patients are encouraged to monitor their PEF at home to detect worsening asthma before symptoms become severe. Recognizing patterns in PEF can help guide treatment adjustments and prompt early intervention. Overall, the integration of PFTS into the routine management of asthma provides valuable information for healthcare providers, allowing for tailored treatment plans and the ability to assess response to therapy effectively. Explain how to interpret arterial blood gas bag results in a patient with acute respiratory failure. Provide an example with an ABG result and interpretation. Answer. Vaccination is a critical component of preventive healthcare in managing respiratory diseases. The influenza vaccine is particularly important for high-risk populations, including the elderly, young children, and individuals with chronic respiratory conditions. Annual vaccination is recommended as influenza viruses change frequently, and vaccination helps reduce the risk of severe illness and hospitalization. Additionally, the pneumococcal vaccine protects against pneumococcal pneumonia, a common cause of respiratory infection. The pneumococcal conjugate vaccine (PCV) is typically administered in childhood, while the pneumococcal polysaccharide vaccine (P+V) is recommended for adults aged 65 years and older, or for those with specific risk factors, such as chronic lung disease or immunocompromising conditions. Education regarding smoking cessation is equally vital in preventing respiratory diseases. Smoking is a significant risk factor for chronic obstructive pulmonary disease (COPD) and lung cancer, and cessation programs can substantially reduce the incidence of these conditions.